Yeah, we're bringing a Tuesday VMR. I'm very happy to say that Yasmin's going to co-discuss with me today, and I have a special guest, a student that's rotating here at Sinai will present a case, and as usual, we are blinded to the case, so we don't know what the diagnosis is or what the details of the case is or are. Before we get going, I am just going to make an announcement that this week, Clinical Problem Solvers is undertaking a very special mission. We are currently fundraising for a drastic, very unfortunate circumstances that are currently going on in Pakistan. This affects a lot of us because this is secondary to climate change. And unfortunately, 1/3 of Pakistan is currently underwater. And what I've heard, it will impact over 100,000 people. There's currently a lack of food, medicines. A lot of the area underwater is responsible for production of crops. So there's a lot of crop production there that feeds the population. And there's also now spread of waterborne diseases such as dengue. A week ago, we talked about melioidosis in floodwaters. So unfortunately, this may be prolonged for about 6 months, and this will be an ongoing mission. But for this week, we're going to share links throughout a lot of the VMRs this week to encourage people to maybe contribute as small as possible to help out. It'll be funded through Doctors Without Borders, similar to what we did with Ukraine a few months ago. And we really applaud all of the audience for contributing to the Ukraine effort. We were able to raise over about $7,000. The target was $5,000. So please consider contributing to this effort. So today we have a case presentation, but before that, I'm going to ask Yasmin, who'll be co-discussing, to unmute her mic and just introduce herself and tell us a little bit about herself.
Hello, everyone. I'm Yasmin. I am a medical graduate from Mexico. I am very happy to be here. I'm kind of nervous for discussing today with Dr. Ravi. And right now I'm preparing for my steps. So wish me luck.
Good luck, Yasmin. You're going to knock it out of the ballpark. I have confidence in you. And we have a medical student, Jessica, who's going to also introduce herself, who will present a case to us. Jessica?
Hi, my name's Jessica. I am a medical student from BCom that's been rotating at Sinai. So I've been rotating with Dr. Ravi and then another resident, Franco, who told me about this. So I'm really excited to present this case.
Awesome. And Jessica, what do you like to do outside of medicine when you're not rounding on the floors and reading and presenting?
What do you mean in my free time? No, I like to swim. I really enjoy swimming, and it's kind of a different mode than walking around. So I think it's pretty cool just as a change of scenery. Awesome.
Awesome. All right. So we'll have Shema also helping with, I think, teaching point scribing, and Franco is here actually, is off service. So Franco will also help out. So we'll deploy the whiteboard. Jessica, the first aliquot, please.
So the chief complaint was shortness of breath. And the HPI, we have a 48-year-old male with a past medical history of hypertension, hyperlipidemia, and a recent NSTEMI that was 2 weeks prior to this current admission, who presented to the ED with 2 weeks of progressive shortness of breath. He reported that the shortness of breath was present with moderate activity, and then he had an unclear history of orthopnea and paroxysmal nocturnal dyspnea. He was previously admitted for an NSTEMI 2 weeks prior to the admission, and had a catheterization that was negative for any blockages. At that time, he had complained of 1 day of chest pain and on rest, along with shortness of breath, diaphoresis, and nausea. He was found to have an elevated troponin up to 2,536, and an EKG significant for sinus tachycardia with a rate of 124 with slight T-wave flattening. He had a catheterization that showed no significant obstructive CAD and probable small vessel disease, and he was discharged on aspirin, atorvastatin, lisinopril, and metoprolol. He was planned to have an outpatient echocardiogram, but never actually was able to complete that. After discharge and when he came back, he endorsed progressive shortness of breath with exertion, and he was not able to climb one flight of stairs. He occasionally woke up at night feeling shortness of breath and needed to get up to have that relieved. He also reported intermittent cough with whitish sputum, as well as some nausea and loss of appetite, and denied chest pain, lightheadedness, palpitations, chills, and fever.
Awesome. A lot of details there, but I'm going to ask Yasmin to see what she thinks about this.
Of course. First of all, this is a patient that has a lot of cardiac history here. And if I see a patient coming to the ER or to the office like this, I will look for red flags, which is the first thing, the dyspnea rest, if the chest pain, diaphoresis, I will look for the low oxygen saturation, if there are signs of increased work of breathing. I would definitely, the first thing I would do with this patient is look at his vitals, if there is hypertension, if there is pulsus paradoxus, which would indicate that maybe this person is having a cardiac tamponade constrictive pericarditis, or even a massive pulmonary embolism, or any other stuff like new murmurs. We'll also look for hypoxemia or how is his level of consciousness, agitation. And then right now for the cause of dyspnea, I would, due to his history also, I would definitely group them into cardiac issues mainly. If this is a heart failure exacerbation, because he has a lot of symptoms right now. I know that we haven't got to the aliquot there, but I would definitely ask for natriuretic peptide, troponin, look at his sodium, ask for an X-ray, look what is going on in that chest, especially with that heart, because that's the main thing I'm looking at, something cardiac. What do you think?
Awesome. I love that approach you just mentioned. What could be dangerous? And it always disturbs me when a patient returns back. So they've already undergone some sort of treatment or have a diagnosis, but when they return back, I'm always worried about, was there something missed? Did they carry something home with them that could have just flourished and ramped up and now has manifested with the second presentation? So if we think about what could be life-threatening, you nail all the different things. And the cardiac, initially they had a cardiac issue. Could this be something secondary to the cardiac disorder that the patient has? So NSTEMI, worry about, okay, was there myocardial injury significant enough to cause LV dysfunction? Could this be congestive heart failure exacerbation? Could this also be a extension or re-extension of a myocardial infarction? At that time, a patient had a cath which was negative for obstructive coronary artery disease, but could they now be obstructive? Well, obstructive coronary artery disease or non-obstructive coronary artery disease. So what kind of non-obstructive disorders can cause a myocardial infarction? You could have a clot, you could have embolization, you could have vasoconstriction, you could have dissection. So many different things could manifest. You could have a connective tissue disease, and you could have aneurysm, you could have dissection or something like that that could be manifested. I see you also put in the chat, Yasmin, evolution like papillary muscle ruptures, or something that could have triggered maybe congestive heart failure, but dyspnea is the main, or shortness of breath is the main presenting complaint here. So what could dyspnea also be other than just water or congestive heart failure, pulmonary edema? Infection. Many times patients could leave the hospital and carry home a hospital-acquired infection. So hospital-associated pneumonia could definitely be entertained here as well, and pulmonary embolism. So we always wonder, when you're hospitalized, what do we do to our patients? We ask them not to move around, especially when you have a myocardial infarction, not to roam around the floors of the hospital. So immobilization, inflammation could be prothrombotic disorders. So a few things to think about. Valvulopathies, no lightheadedness, no palpitations, chills and fever, well, they don't necessarily discount infections. At this point, I think that's pretty much what I have to say. Progressive shortness of breath with exertion, not able to climb one flight of stairs, that is very concerning, especially if his baseline activity was fully functional. So again, LV dysfunction, valvulopathies come into play. Where else could this happen? Pleural effusion. We're basically discussing disorders of the cardiac and respiratory system. Anything else, Yasmin, that's coming to mind before we?
Due to the evolution of this patient and having, just throwing this as a pearl, maybe if it's almost 2 weeks, he could have had a ventricular free wall rupture that could give us cardiac tamponade. I would definitely look at that. I would take this patient directly to imaging, because like, I try to situate myself in a real case scenario. That's the first thing I would do.
Oh, awesome. You just reminded me. Yeah, you hit the nail on the head there. Complications of myocardial infarction. So yes, ventricular free wall rupture, pericarditis, but it usually happens weeks on out, Dressler's syndrome. You could get papillary muscle rupture. Left ventricular aneurysm could also manifest post-MI. So there are a number of things, especially NSAIDs or steroids can impair ventricular healing after an MI and could predispose the patient to having a rupture. And lisinopril is interesting. ACE inhibitor-induced cough. There's also this syndrome of cough with this patient. I'm just wondering, ACE inhibitor-induced cough is quite common, and we do see that. So that's something to think about. If this patient had undergone coronary stenting, I'm just going to sort of go off on a tangent. Commonly, we use antiplatelet agents, so aspirin and ticagrelor. And what is notorious with ticagrelor is it can induce shortness of breath in patients. So you do see patients coming back with shortness of breath that have had coronary stenting and have been put on this medication. So another thought, but this isn't relevant here because the patient did not receive a stent nor was placed on ticagrelor. And Ilya Mirzai mentions, I'm just going to highlight the chat, wouldn't ruptures be associated with STEMI? So absolutely right, yeah. So could this have morphed from NSTEMI to STEMI during this time as well? But you're absolutely right. We need to make sure that these complications are due to a full thickness myocardial injury rather than a subendocardial or non-ST elevation MI. Okay, Jessica, the next aliquot, please.
Okay, so his past medical history, kind of already mentioned it. He had hypertension, hyperlipidemia, and then an NSTEMI that was 2 weeks prior to this admission. For his social history, he denied alcohol abuse, substance abuse, and tobacco abuse, including smokeless tobacco. He also worked as a pastor in a local church and as a school bus assistant. For his family history, he had a father with quote unquote heart issues at age less than 50, but was unable to really specify what those heart issues were. For his surgical history, he had the catheterization 2 weeks prior to admission, but no other surgeries. For his allergies, he had no known drug allergies. And then for his medications, he was on aspirin 81 milligrams Q-day, atorvastatin 40 milligrams Q-day, lisinopril 10 milligrams Q-day, and metoprolol 50 milligrams BID. Did you want me to continue with
Yeah, I think we can include the physical exam, then we'll stop there and have Yasmin discuss.
So for his vitals, he had a blood pressure of 108/80s, a heart rate of 101, a respiratory rate of 18, a temperature max of 36.5, and an oxygen sat of 99 on room air. Generally, he was well appearing, well nourished, and no acute distress. He was oriented X3, and he had normal mood and affect. He had no rashes or prominent lesions. For HENT, he was normal cephalic, atraumatic. His conjunctiva were clear, and mucous membranes were moist. His neck was supple without adenopathy, no carotid bruit auscultated, and no JVD. For his heart, he was tachycardic and had no murmurs. His lungs, his breath sounds were diminished in bilateral bases, and he had bilateral rales, but breathing was unlabored. Abdomen was soft and non-tender, no masses, and extremities, no deformities, no clubbing, no edema, no cyanosis. For neuro, he was alert and oriented X3, no focal deficits, and speech was normal rate and tone.
Just one question, Jessica. What was the pulse ox?
The pulse ox was 99 on room air.
Great, thank you. This is interesting, Yasmin. What do you think?
No, I don't think this is, I'm thinking more as maybe he's having an effusion, because there is like diminished sounds in bilateral bases of the pulmonary area. But still, he's not tachycardic, there are no murmurs, so we can scratch a lot of things, scratch away a lot of things that I already said. But he's tachycardic, so, and also we don't really know his blood pressure, his baseline blood pressure. Maybe that blood pressure is low for him. So I would still think there may be a tamponade going on over there, or even a pericardial effusion. I am not taking that away from the table still, because there is, I would definitely not scratch those two. What do you think?
Absolutely. I'm going to borrow your table for a minute. And I just think those are wonderful thoughts here. Could we be wrong in focusing again on the heart here? If you look at the heart rate, I really like that you focused in on it. The patient is technically tachycardic while being on a beta blocker. So what is the ideal heart rate we aim for anybody with cardiac disease, post-MI, congestive heart failure? Ideally 60, maybe to 70. So you want to titrate up that metoprolol slowly. But in this case, this patient's coming in with a heart rate of 101. So without a beta blocker, I would anticipate it to be higher than this. The blood pressure is on the lower side. Again, this could be secondary to these medications that the patient was started on. And I don't see hypertension in the past medical history. Do I? Yes, I do see it. Sorry. Tachycardia, again, is it the fever of the heart? Is it secondary to response somewhere else? Anemia could cause tachycardia. It's likely not an arrhythmia unless we get the EKG. If it's just sinus tachycardia, there was sinus tachycardia mentioned in the history, but on this occasion, I definitely would like to see if there's a new arrhythmia that's developed, something like atrial fibrillation due to stress or cardiac changes. In smokers, COPD, we may see MAT. So it depends on if the arrhythmia could be regular or irregular, but most commonly we may see sinus tachycardia. There's no murmurs, there's no JVD. Does that necessarily rule out pericardial tamponade? Not so. I have personally seen, we always learn the triad. The triad gives you a foundation to learn these features, but then you have to be prepared to see atypically presenting cases. So I have seen tamponade without JVD, without muffled heart sounds, maybe with just hypotension, and not necessarily with the pericardial friction rub or on EKG the sinus arrhythmia, or what we call it, the alternating current that we get on an EKG that can be pathognomonic for pericardial effusion. Now, what's interesting here is the diminished sounds in the bilateral bases. And is that, Jessica, is it rails diminished, but we hear rails above the diminished breath sounds?
Yeah. So there was kind of scattered rails throughout, but then on the bases, it was just diminished.
So that's very powerful there. And I think Yasmin had mentioned that maybe the clue is in this examination here. The tachycardia is just due to deficiency in the respiratory system. So diminished breath sounds at the bases could either be atelectasis, and with decreased alveolar filling, you get a rise in the diaphragms upwards if you do an X-ray. When you percuss, there may be dullness to percussion. Other thing that could take the place of air sounds, I doubt bilateral pneumothorax, but patient will be severely symptomatic then in that case. Pleural effusions could be very interesting. You could get a dull bass, and above that some atelectasis, which could cause some crackles. And then diffuse rales, as Yasmin mentioned, also Dania is in saying in the chat, could there be pulmonary edema? So rales could be secondary to pulmonary edema, could be due to inflammation in the lung. We don't know yet, but I would love some imaging to try and discern this. Anything else that could cause diminished bilateral bass sounds? I guess that pretty much that's what I have on my radar screen. Any other thoughts, Yasmin, before we keep going?
I'm definitely there with you. I would not take away pleural effusion, pulmonary edema, especially with those sounds, and also look at why is that heart rate, what is making that heart rate so high, even if he's on these meds. So yeah, let's see the next aliquot. I'm really very interested in what the imaging and screen and tests have to say.
Right. Just before we get the labs, this still could be congestive heart failure, although we're not seeing a lot of signal for it. No JVP, no peripheral edema, no hepatomegaly or congestive hepatopathy. There is orthopnea. There is increased work of breathing, climbing a flight of stairs. Occasionally wakes at night, feeling short of breath, PND. Could there be bendopnea? When you go upstairs, you sort of bend over. Could that be similar to bendopnea? So all of that is suggestive of congestive heart failure, but we're not seeing a lot of clues in the physical exam. So, but does heart failure always manifest with all of these physical exam findings? They don't necessarily have those findings. You can have very atypical presentations. And what exactly is a definition of congestive heart failure? Is where the heart's not able to meet the metabolic demands of the body. So maybe maybe we can identify heart failure through laboratory clues, pro-BNP, lactate, maybe a rise in BUN creatinine, maybe a rise in AST/ALT. So wherever there's congestion in the organs, we may see some abnormal labs. Back to you, Jessica.
Okay, so his labs were significant for a white blood cell count of 5.99, hemoglobin of 13.1, a hematocrit of 39.5, and a platelet count of 337. His chemistry was a sodium of 142, a potassium of 4.1, a bicarb of 25.5, a BUN of 20, a creatinine of 1.21, and he had a baseline of 0.99 in his admission 2 weeks prior, a glucose of 140, and then he had a troponin of 62, which, just a reminder, his prior admission had a troponin of 2536, 2,536. Then he had LFTs that were elevated with an AST of 157, an ALT of 181, and a total bilirubin of 2, and then a negative procalcitonin. And I thought I had the pro-BNP on here. I know it was elevated, but I somehow lost it in here, so I can see if I can find it. Let me just pull up his chart. Did you want me to say the imaging as well? Or hold off?
Let's hold there a second. Let's see if we can narrow our hypothesis or come to a conclusion using the lab. See if we can use this to prioritize some of the diagnosis that we're entertaining. What do you think, Yasmin?
I'm thinking, okay, for a minute, I was thinking maybe it could be like a flash pulmonary edema, but this patient doesn't have hypertension. This can occur in people that have acute decompensated heart failure, but he would definitely have more, he would have a picture like with more symptoms. And I also think that this creatinine, what is making his creatinine go up? I wouldn't, I would like to see what's going on with that kidney too, because maybe for some reason, so something is telling me that that heart rate and that pressure is not normal. It's not, it doesn't go well. And then I would think that there's something with the blood pressure. I definitely want to see what's up with that. Like maybe on like screen test, imaging test, we will see what's going on there. But that heart rate with that blood pressure is not congruent. Well, I don't know what you think.
Yeah,
I can't put my finger on it yet.
I love your hunches. What I'm just glad to see is that working through a difficult case like this, and I just want to tell the audience, I just sprung a surprise. I asked Yasmin, could you co-discuss with me, because it kind of gets it's difficult to run this solo. So I'm sort of springboarding ideas. I'm listening to Yasmin. I'm like thinking like, is her thinking paralleling mine? And a lot of it is. So she's doing a spectacular job. Phenomenal job with analyzing this and seeing if this really moves the needle forward in trying to support our hypothesis here of congestive heart failure. It still is something that is bothering me, but I also want to keep an eye on other causes. You know, we have several systems here that are at play. One cause of dyspnea, shortness of breath, is anemia. So we can take that off the table. I'm going to borrow Yasmin's table, take the anemia diagnosis off of that. And what's left is still all the different cardiac disorders. And again, namely, could there be another myocardial infarction? Interesting that the troponin is elevated, but less than before. So anytime a patient with STEMI and STEMI comes back, the troponin, when you repeat it, will be elevated, but it will be trending downwards because it does take some time to decrease. The proBNP is elevated. We don't have a number, but it's elevated.
Dr. Ravi, it's actually, no, it's okay. I had to look it up. It's 4,506.
So interpreting that in the context of what's going on here, could this signal heart failure? It could. But proBNP can be influenced by many different things. It can be cleared by the kidney. So we do have some kidney dysfunction here. So maybe it's more exaggerated than it should be. The same thing, procalcitonin could be affected in that way as well. But I think very less likely that we're considering an infectious etiology for this presentation. But again, back to the cardiac dysfunction, this could help support our hypothesis. AST, ALT, and renal dysfunction. This could also be signal or markers of right-sided heart failure. So as we all know, renal dysfunction could be an impairment in forward flow and also backward flow. So through the renal vasculature, namely the venous system, there could be renal dysfunction. They also could be, if you do have like a STEMI and LV dysfunction, low ejection fraction, you could have cardiorenal syndrome. But I think this is all right-sided issues here. And also the liver is involved. So I assume the liver was fine to begin with in this acute elevation. Namely, it's not cholestatic, it's hepatocellular. So this could also be due to a congestive picture. Any ideas, Yasmin, before? Maybe imaging will help us at this point.
I just want to go to the imaging right now. Like, I really want to see what's up with there.
All right, let's go imaging.
Okay, so he had a chest x-ray that showed new small bilateral pleural effusions and mild cardiomegaly. We have an EKG that showed sinus tach of 127 and T-wave inversions on the lateral leads. And then a CTA that showed it was mostly normal without PE or aortic dissection. And then there was an increasing opacity in the right lower lobe.
Interesting. Does that help us, Yasmin? What do you think?
Well, first of all, the inverted T waves, the first thing that I'm going to be looking at is he had my previous anstomy, but it could also tell us maybe what about pulmonary embolism, what about hypertrophic cardiomyopathy, and what about ventricular hypertrophy. That pulmonary embolism and hypertrophic cardiomyopathy will be the first thing that jumped to mind after listening to inverted T waves. And also we have there the pleural effusions, which could explain what our findings on the physical exam. But now I would go mainly to something, cardiomyopathy or embolism. Both, one of those two. What do you think?
Yeah, it was interesting. So we found on the imaging something to support one of our thoughts, which was pleural effusion. Pleural effusions can definitely introduce shortness of breath, especially with function. And here we don't have a patient with pre-existing respiratory disease like COPD, like pulmonary fibrosis, like asthma, where they could have reduced lung capacity. So a patient with pre-existing lung disease may manifest much earlier with respiratory disease and probably with more symptomatic presentation. But this patient is a younger patient who's not had any respiratory disorder, now suddenly has pleural effusions. And that can also be part of the congestive heart failure complex. They're bilateral, so very likely due to CHF. But of course, we have to at least do a thoracentesis and determine if this is exudative or transudative. The CT, it does help. Actually, they found no PE. So in one of our list of life-threatening causes, PE was definitely there. As we had mentioned, patient had gone home from hospitalization, and that definitely could be a diagnosis that we need to exclude. So that's off the table, no aortic dissection. I would expect at least chest pain or back pain with this patient. Aortic dissection can have a very traumatic presentation, so or devastating presentation. So I would want to see some signal in the history there. And then cardiomegaly, when you have cardiomegaly, pleural effusions, congestive changes on the X-ray, curly B lines, interstitial enhancement, this could all on an X-ray suggest congestive heart failure. But then there's an increasing opacity on the right lower lobe with a CT, and sometimes CT can actually give you that extra definition if there's an evolving pneumonia that an X-ray may not be able to manifest with. So a right lower lobe opacity on top of pleural effusions, what could that be? What do you think, Yasmin?
I would think, okay, so we could have I don't know, what would you think about like pleural effusion or pericardial effusion also? And yes, it could be something infectious. We could think something bacterial, mainly because of his past hospitalization. And what about yeah, something bacterial? I don't know, like staph aureus. I have no. I would just think that. Or
Yeah.
it could be infectious, or two, it could be something damaging the structure of the heart. That's my two options. But yeah, like you said, definitely determine if it's exudative. What's the nature of this effusions?
Yeah, it's very puzzling. I don't know what this right lower lobe process is. Usually you aspirate right middle lobe, supposedly, or superior segment of the right lower lobe, depending on what position. So pneumonia, an increasing opacity could be suggestive of pneumonia. But again, I didn't see a fever. I don't see tachypnea, although the respiratory rate's 18, not above 20. I don't see hypoxemia. So a lot of features aren't really suggestive of pneumonia here. And a Y count, the Y count is normal. So very unlikely pneumonia. But then again, these labs are a snapshot in time, and this could be a developing pneumonia always. What else could that right low lobe process be? Opacity? Could it be a tumor that was there with post-obstructive pneumonia? Could it be some other abnormality? I really don't know. Nothing's really coming to mind, or I can't describe it here, but it's definitely perplexed me. And let's see if there's anybody in the chat. Yeah, an echo would be very helpful to see. Could there be a complex coming off? So the right middle lobe is right abutting next to the right side of the heart. So right lower lobe will be closer to the liver and the costophrenic angle. Could there be an offshoot from the heart? So something with the pericardium, thinking some esoteric sort of phenomena. So could it be a lung issue? Could it be a diaphragmatic hernia? Could it be a pneumonia? Could it be a pericardial cyst? I am not quite sure yet, but looking at the CT might help us. Try looking at the little features sometimes could help. I doubt it's bowel or bowel hernia. There would be at least gas in this complex too. But I'm going to ask Jessica, is there any other test before you tell us the final diagnosis?
So the next test that I tell you actually will give away the final diagnosis.
Oh, okay. So Yasmin, any final thoughts before we?
Yeah, I was reading in the chat, like, what about hypertrophy? Like, the only thing that puzzles me here is that the cardiac is not making any, the cardiac part is not making any issues. You're not giving me any murmur, any gallop. If you will tell me, oh, he has a systolic ejection murmur, if he had a S4 gallop, I would definitely go like Ilias and a hypertrophic obstructive cardiomyopathy. Or if he had any other kind of murmurs, I would say something in the valve. But what it's really making me confused right now is that the heart is silent. Like, he's just tachycardic, but it's not making any sound. So I'm really intrigued. What is going on with this patient?
I love that term you just used, silent. It's sort of like a, silent service, sort of like a submarine. It's sort of going along without really exclaiming, I have a problem and this is what's causing the shortness of breath. And there was a nice comment by Ilya talking about HOCM, and there are a couple of EKG changes that you sort of must know, especially with syncope in a young patient. And HOCM has a great signature on an EKG, which is these dagger sort of Q waves, and it's something you just can't miss. But that's also a great thought. Oh, Dr. Dancell's in the chat as well. Cardiomegaly on X-ray can be pericardial effusion. So POCUS, yeah, we don't have POCUS VMR today, but a POCUS, I would definitely take POCUS to the bedside.
Yeah, we need a POCUS right now.
We do need. I would consult Dr. Dancell to come help with a POCUS. Okay, Jessica, let's see if you can help us get this diagnosis.
Okay, so he received an echo, and that showed the left ventricle mildly dilated, the left atria mildly dilated. He had an EF of 10 to 20%, and then there appears to be a large mural thrombus adherent to the apex of the left ventricle.
Wow. So what was the right process then? Was it related to it doesn't, yeah. I'm having trouble trying to relate the right low lobe.
Are you asking about the opacity in
Yeah.
the? Yeah, so I don't think we really ever figured that out, because he had a negative procalcitonin, so bacterial pneumonia was kind of lower on our differential. He was a 48-year-old man, didn't really have any trouble swallowing, and it was right lower lobe, not middle lobe. So we thought aspiration pneumonia was probably not as likely. It was unilateral. So I think somebody said this in the chat. We didn't really feel like it was cardiac. So we're actually not sure. And when we had treated him for the heart failure, with Lasix and then gave him heparin for the clot, his symptoms actually improved. So I don't think we ever really chased the opacity.
Oh, interesting. And so going back to 2 weeks ago and STEMI, I assume at that time he had normal LV function on the cath.
Yes.
Ooh, that's radical. So Yasmin, over 2 weeks after the end STEMI, and usually a STEMI can cause significant LV dysfunction because of transmural myocardial infarction. So the end STEMI morphed into this systolic dysfunction, heart failure with reduced ejection fraction. So then he namely came back with a clot, and due to decreased LV function, and a drastically decreased LV function at such a young age. So unbelievable,
Totally.
unbelievable.
Yeah, it's totally like confusing for me, because I know that thrombus are most likely seen on patients with STEMI, with actually, and it's normally in the territory of the left anterior descending coronary artery. And because it's a big myocardial infarction, the muscle is poorly contracting, so the blood movement is sluggish, and it causes our thrombus to be there, right? So seeing this patient with an end STEMI with a thrombus is something that is definitely, it took me by surprise. But it will make, and it will make like it would make sense, like tachycardia. Although, yeah, like the lack of sound there, maybe I would have expected any type of regurgitation, because his ejection fraction is really, it's low. Like, I don't know, correct me if I'm wrong, this is a systolic heart failure. So I would expect something else going on, like any other characteristic, any other symptom from the heart.
Yeah, absolutely. If we walk it back, Yasmin, we were very much talking about a systolic dysfunction in a patient, right? And all the wonderful associated findings, and the PND and these features. I guess the evidence was in the HPI, PND, orthopnea, climbing stairs. He's had shortness of breath post MI, but he had an STEMI. If he had a STEMI, it'd be very obvious that the LVF was diminished due to the injury. But he went from an STEMI to LV dysfunction. Definitely needs to be worked up. And going through the tachycardia, when you have congestive heart failure, you have sympathetic surge. So the heart rate goes up, and that's why we clamp it down or put a damper on it with metoprolol, because with tachycardia, there's impaired left ventricular filling, or less time for diastole and more time for congestion. But looking to the labs, there was a signal with creatinine, with the liver enzymes. So these were abnormal, and then a pro-BNP was abnormal. But then again, it helps to make the diagnosis, but it doesn't give us the diagnosis. So we consider with all of the other features that we were discussing. So great discussion, Yasmin. I really appreciate you coming on. It's been fun.
Now that I'm reading before I forget, this patient has beta blockers in it. So I remember having read something about it, like the issue with the beta blocker in a patient that had myocardial infarction, ischemic issues. There are studies that have reported higher frequency of thrombus development in patients with beta blockers, precisely because of the negative inotropic action of these drugs causing blood stasis. So maybe that's why, even if it's an STEMI, it's because we have other factors contributing to it.
Yeah. And we definitely have to we have to consider this LV thrombus as a potential to cause systemic issues like embolization. It can embolize anywhere into the superior mesenteric artery, into even the coronary vessels, and trigger an MI, because the coronary sinus is right above that. So it, the embolus breaks off and travels up into the aorta, and the coronary arteries take off right after that. So a lot of potential for systemic disease with this clot. So it must be addressed immediately. Okay, sorry.
Add something. Somebody had mentioned in the chat, they asked if he had COVID in the last year. We actually asked that initially because when he came, it almost seemed like a viral presentation. He had not had COVID in the last year that he had known of. And he was fully vaccinated and had his booster. In addition, we did not get a hypercoagulable panel inpatient, but we were planning to have him follow up with a cardiologist to get that done. He also had to wear a life vest for, I believe, 3 months, and they were going to reevaluate him to see if he would need a defibrillator permanently.
Yeah, absolutely. Putting the patient on guideline-directed medical therapy could reverse some of this LV dysfunction. So we bring the patient back 90 days after diagnosis of heart failure or 45 days post-MI. So in this case, it's very confusing because he had an NSTEMI. So 45 days post-MI to see if there's an improvement in LV dysfunction before considering placement of a defibrillator. We can go to teaching points. We have both the tag team, Deborah and Shema. Take it away.
So, hello everyone. We had an amazing discussion. Thank you, Ravi and Yasmin, and also amazing case. So, as a chief complaint of shortness of breath, as you know, we prioritize always cardiac and pulmonary issues next to others. And you also talked about bendopnea as a possible symptom of heart failure. And it's basically dyspnea that is occurring when bending over within the first 30 seconds, which is a clue for advanced heart failure, but it is also associated with a high right atrial pressure and also high wedge pressure. And then we were also talking about the complications of myocardial infarction, like think of papillary muscle rupture, ventricular rupture, aneurysms, also Dressler syndrome, which is an autoimmune mediated post-myocardial pericarditis, next to other things like tamponade. And then talking about the Beck's triad, which is a clue for a possible cardiac tamponade, so the triad of high JVP, muffled heart sounds, and hypotension with a narrow pulse pressure. And for EKG signs of tamponade, look for electrical alternance or low voltage. And then I would bend over to Deborah.
Hi, everyone. It was a teamwork here. So, and continue for our teaching points, the tachycardia of the patient. He has a history already from tachycardia, but we thought that this one could be a new one from anemia, atrial fibrillation, could be the deficiency in the respiratory system, and the diminished breath sounds at the base, could be the alveoli filled with or collapsed, and the diffuse rate could be pulmonary edema, inflammations of the lungs, and elevated BNP. It's an indicator of heart failure. The key question is, where does it come from? Influenced by the kidney dysfunction, age, pulmonary hypertension, sepsis, diabetes, liver, and cirrhosis. Liver, that could be a cirrhosis. The T-wave inversions we thought about, that could be a specific myocardial ischemia. And in the CT, the patient presented increasing opacity of the right lower lobe. And we thought about pneumonia, tumor, obstructive pneumonia. And then we learned about the cardiomegaly, that could be a pericardial effusion, but we can use focus, as Dr. Ria said, that could help. And the final part is that the left ventricle thrombus is a complication of acute myocardial infarction. It's associated with systemic thromboembolism, and most left ventricle thrombin develop with the first 2 weeks post-acute myocardial infection. So thank you, everyone. It was a great case.
Thank you, Shema and Deborah. Great teaching points presentation. Thank you, Yasmin, for co-discussing. And Jessica, a fantastic case. So take care, everybody. Have a great rest of the Tuesday, and be back tomorrow, 4:30 Pacific time, 7:30 for VMR with Charmin and Jack. Take care.
I just have a
Bye.
question.
Sure.
Oh, yeah. So I was just kind of thinking about what role COVID could play in kind of a more mysterious presentation of a cardiac complication, and whether you would think about COVID at all.
Oh, definitely. The fact I have to look into the case to see if the patient did present, if maybe the patient was asymptomatic, it definitely can cause cardiomyopathy in patients. Although initially when they did the cath, there was non-obstructive coronary artery disease. So for this MI, they'd have to take a look at other causes, which could be, you could have spontaneous clot, possibly. You could have vasospasm causing an MI. You could have dissection, although you would see a dissection on a cath. So there's a myriad of potential causes. A viral cause is interesting. COVID has been known to cause hypercoagulable disorders. So that could cause possibly a clot. And clots can disappear immediately as the body can produce clots and also lyse clots during the same time. So, and then what's interesting, I've yet to see an NSTEMI morph into STEMI like this, where a patient suffers severe LV dysfunction post NSTEMI. So that could potentially, a lot of people are thinking about this, and COVID is the hot button topic at the moment. So it's something to definitely think about with such severe LV dysfunction. 2 weeks post MI and STEMI with LV dysfunction, very unusual for, say, tachycardia, a viral induced MI, I would say. I have to look at that again. I'm not entirely sure. But yeah, tachycardia induced LV dysfunction can happen. So we have patients with arrhythmias and tachycardia, and their muscle can tire out. That's something I'm also interested in. So with this patient, it's interesting. They had an NSTEMI and then a cardiomyopathy, and they left with normal LV dysfunction. So something transpired between discharge and readmission. But the tachycardia is something I'm very interested in causing cardiomyopathy.
Yeah, really interesting case.
Yeah. All right, thanks. Thanks for that question. Okay, take care, everybody. Bye.